Okay, can you hear me in the back? No? Oh, it's still talking, saying the webinar is getting ready to begin. Okay. Okay, everyone hears me? Very good. Let me get this out of the way so you can see. And good afternoon. I know our Miami group is gathered together to listen to this presentation, and we have some people with the Licensure and Reimbursement Committee with USLCA who also are online. So we'll get started now. If my computer will cooperate. It's not advancing my slides. There we go. Okay. My disclosure, I've been an accredited Lactation League leader since September of 1977 and an IBCLC since 1996. I work at Sunshine Pediatrics as their staff of IBCLC. I also have a private practice in their office. I do not rent or sell breast pumps. I have designed and marketed the Lactation Visit Receipt Packet since 2001. I'm a founder and the present president of the Florida Breastfeeding Coalition. I'm not being paid by or have any connection with any commercial enterprise, which would be in violation of the WHO code. And some breastfeeding history, since this is about breastfeeding, past, present, and future, and also about the profession of IBCLC, past, present, and future. We're going to start out with breastfeeding history, and in the beginning, 100% of humans were breastfed, just like all other mammals. And I love this video. If some of you have seen it, it doesn't hurt to see it again, but I'm going to play this video for us. It really covers the breastfeeding history from 1900s to now. We need more volume. Let me just give everyone more volume, and we'll start over again. Didn't realize that would be a problem. And now we have less volume.
Perfect food. For a long, long time, breastfeeding rates were close to 100%. A very long time. As the 19th century gave way to the 20th, most babies in the United States were breastfed. For the tiny percentage of babies who needed an alternative, the invention of infant formula was a good thing. Yet, as the years rolled on, mothers began to switch to formula feeding, even for babies who didn't need it. The formula makers became very good at marketing. Formula itself improved, and women increasingly chose to bottle feed their babies. Hospitals built nurseries to protect infants from germs and bacteria, but that meant separating newborns from mothers at birth. Women joined the workforce in steadily increasing numbers, many in the service industry. Yet public policies around breastfeeding weren't supportive of working women. Formula came to be seen as a status symbol, while breastfeeding was viewed as out of step with a modern woman's lifestyle. Several generations of African American women grew up without seeing or knowing of their mothers or grandmothers breastfeeding. By 1972, the low point, just 22% of babies in the United States were given any breast milk. And then something happened. Pioneering young women began to question the status quo. Enough. This isn't natural. The Lactation League, founded in the 1950s by 7 mothers, gained traction in its advocacy to promote breastfeeding. Women of color found their voice in the outcry against aggressive marketing of formula in Africa and other less economically developed countries. Breastfeeding rates began to rise. International organizations, government agencies, public health officials, and healthcare professionals lent their support. Surgeon General C. Everett Koop held a workshop on breastfeeding. 6 years later, WHO and UNICEF issued the Innocenti Declaration to encourage and enable all women to breastfeed their babies. The following year, they established the Baby family-friendly hospital initiative. Breastfeeding rates climbed a little higher. The United States Breastfeeding Committee came together around a national agenda for protecting, promoting, and supporting breastfeeding. At the first annual summit on breastfeeding, maternal and infant health experts and policymakers gathered to align their efforts. The Affordable Care Act passed with provisions for workplace and healthcare support. A breastfeeding movement was underway. When Surgeon General Regina M. Benjamin issued her call to action to support breastfeeding, the movement was there to hear the word and pass it on. That movement is you. All of you have been making it easier for women to breastfeed. All of you are helping ensure more babies benefit from breast milk as their first food experience. Let's keep growing a first food movement together, naturally.
Isn't that lovely? I don't know if you've seen it before, but I can't see it enough times because I just think it's really lovely. And it should make you all feel good because that movement is you. And so it kind of gives me goosebumps when I think about that movement. It's all of us together. So it was about 1920 when the formula companies came on the scene in this country, and very quickly, by 1950, it had really taken hold. In 1963, there was a publication that was put out every year by the U.S. Bureau of Children's Bureau called Infant Care. And in the corner there's a 1939 copy. That's what it looked like. But in 1963, this is what you could find in it. You may feel some resistance to the idea of such intimacy with your infant who at first seems like a stranger. To some mothers, it seems better to keep the baby at arm's length, so to speak. So feeding plans which are not so close. Can you imagine that mothers thought that? That the government actually had this in their booklet about infant care? That you wouldn't want to get that close with a little stranger that you've been carrying for 9 months. Oh dear. So in 1956, we had what I call the Renaissance of breastfeeding began. 7 women in Franklin Park who were successfully breastfeeding their babies had friends asking them how they had been so successful, what they had done, and why this worked for them, but it didn't work for those mothers that were asking the questions. And so they formed what started out to be a peer support group in Franklin Park, Illinois. It was just meant to help those mothers in their community. And very rapidly, they were getting phone calls, and women all over the country were asking questions and coming to these women. And very quickly, an international organization took hold and became an international organization. I wanted to talk about what happened in the 60s, only because there's a lot of things that influence what happens in our culture and our society. And so it's not just women going back to work when the men went away to war, and the First World War and the Second World War that kind of took the mother out of the home, and so it became easier to use formula than it was to breastfeed because if you're working in a factory, it's kind of hard to. Back then there were no pumps and lovely things like we have today to help us out when we're in the workplace. In 1960, the government did the bailout for the dairy industry. The dairy industry wasn't doing so good, so the government likes to step in when someone isn't doing so good and bail them out. So they started buying milk and stockpiling this milk, and then they had all this milk, and they didn't know what to do with it. So they decided that they would make it into a free cheese program for the elderly and the low income. And then in 1966, they still had too much milk, so they started a special milk program for school children. And in the 1970s, they did the Women, Infant, and Children's Program, and by 1977, it was here to stay, and it became an official program. But the motivation behind this was the dairy industry, and then this shows how government policies and economics can also play into this picture of who breastfeeds or what happens with breastfeeding. I wanted to give you a little history about myself. My first baby was born in 1972. That's when we were at the rock bottom in all of history, and as long as this world has been here, we were at our rock bottom. And probably the reason I chose to breastfeed because I'd seen my mother breastfeed my little sister who's 9 years younger than me. So probably this is interesting. I don't know. I've never had this happen before. This is very, very interesting. Okay. Okay. So anyway, I breastfed my baby in 1972, and she was breastfed for about 2 months when I had a medical problem. The doctor said, you have to wean her. You can't continue this. We have to do this surgery. And I didn't know any better because I didn't know anybody other than my mother who had breastfed, and I didn't know about La Leche League. And so I thought doctors were God back then, and I did what the doctor told me, and I weaned my baby, and I cried a lot. I just wanted to make a side note about in 1972. This was also the year that La Leche League held their 5th international conference. And at that particular conference is the first year they had a physician's breastfeeding seminar. And from that point on, when they had international conferences, they always had a physician's breastfeeding seminar that was in conjunction with it. So La Leche League didn't just help educate mothers and help support mothers in a pure sense, but they also are the ones we have responsible for educating physicians to any degree that they have been educated. La Leche League started that communication with them and also had a conference for them to learn more about breastfeeding. In 1973, I had a neighbor move in who was attending La Leche League meetings, and she asked me to go with her with my bottle-fed baby. And I thought, I can't go to that. I have a bottle-fed baby. And she said, no, come. And you'll be okay. It'll be fine. And so I went, and I never stopped going. I went to 2 or 3 meetings a month. We went all over town to go to different meetings. And I went to toddler meetings and new mom meetings. And so by 1975, when I had my second baby, I knew a lot about breastfeeding. And I breastfed him for over 2 years. In 1977, I was accredited as a La Leche League leader. And in 1982, there were a few of us La Leche League leaders who were asked to participate in a pilot program that was at Florida Hospital South, where La Leche League leaders actually went out on the maternity floor and helped the mothers breastfeed. It was a needs assessment project to evaluate the need and outcome of having lactation help bedside in the hospitals. We went in and we scrubbed. We put on these little jackets. We were given freedom to go to the mother's rooms and see if their baby wasn't there with them, because many times they weren't. We could ask the mother if she would like us to get her baby, and we would go down to the nursery and get her baby and bring it back to her, and push it in the little cart back to her. And we also could go to the charts and open the charts if we wanted to find anything out about this particular mother and baby. And then at the end of our period in the hospital, we would have a little room. We sat down and we did all our charting and our notes about all the mothers that we'd seen and what kind of questions they asked, what kind of assistance we gave them, and so forth. And this was going on in other locations throughout the United States by La Leche League, because they were beginning to feel like sometimes there were situations that they needed more than a La Leche League leader to handle. And we had sort of a system in La Leche League. So if a mother calls us about a drug, we didn't have Tom Hell's book back then. We couldn't just turn to it and say, read what Tom Hell's book said. We had to go to our district advisor, and she had to go to the what do you call it? Yeah, the professional liaison. It could be a week before we got information back. That wasn't timely. So they were seeing that there were times that mothers needed more help and quicker help than what always a La Leche League leader could provide. So in 1982, after they had done their pilot programs and got all their information together, they were, really convinced that they needed to have a profession called lactation consultants. And so they appointed Joanne Scott as the director of the lactation consultant program, and Linda Smith became her assistant. They determined that the program should meet the strictest accreditation standards of the National Commission of Health Certifying Agencies. And they actually loaned them $40,000 to get started with, and they felt strongly that this program should be a totally separate thing from Lactation League International. There was a lot of wisdom back there, a lot of wisdom. So then they facilitated a panel of 60 experts in varying healthcare professions, backgrounds, and geographical location, and these experts were the ones who worked at the foundation for our profession of IBCLCs. They come up with and develop the standards and the competencies and the scope of practices to form our organization. So in 1984, the results was the formation of the International Board of Lactation Consultant Examiners, because the Board of Examiners had to be set up before you could certify or have a certification process. So they applied for their accreditation through the National Commission of Health Certifying Agencies, and they felt it was very important because they needed to have the kind of accreditation that was essential to establish credibility with physicians and other hospitals and other healthcare providers. So the first exam was in 1985, and largely the majority of the people who took that exam that year were Lactation League leaders. There were some nurses, but they were mostly Lactation League leaders. Lactation League leaders were the ones at that time that had the knowledge of breastfeeding. They were, at that time, Lactation League was considered to be the authority in the world on lactation. So they also that year, in July of that year, they formed the International Lactation Consultant Association and held their first meeting. They also made this, the decision to have a journal that was the official journal, the Journal of Human Lactation. In 2008, the Lactation Education Accreditation and Approval Review Committee was formed as a nonprofit organization. Each of these organizations are nonprofit and independent, and that's very important. So they formed this organization with the mission to establish standards for and recognize quality in lactation education. So there's a process to go through to find out if what type of program you're teaching is of the quality to meet the accreditation standards. So this was sponsored by FLCA and FLCA, and they collaborated on the putting this together and sponsoring it. And in 2012, the American Academy of Pediatrics joined as a third sponsor. And it serves as a review committee to recognize academic lactation programs for accreditation by the Commission on Accreditation for Allied Health Education Programs. So there's very many layers of the credentialing that goes behind the designation of IBCLC. To get to that exam, past that exam, there's layers of accreditation. The Committee on Allied Health Education and Accreditation was part of the American Medical Association. It's a post-secondary accrediting agency recognized by the Council of Higher Education Accreditation, and it carries out its accreditation activities in cooperation with 19 review committees. That's a lot of committees to go through. Their board of directors is composed of 15 members and is elected by and among the commissioners, and the board is the accrediting body that awards or denies accreditation after reviewing the accreditation recommendations by the Committee on Accreditation. So I didn't want to list all 60 organizations, so I just listed a few of them here. You can go to their website if you want to see all 60 organizations, but among those organizations, which are some pretty esteemed organizations, are FLCA and FLCA. And what do they say about lactation consultants? They say that the International Board of Lactation Consultant Examiners develops and administers the certification examination for lactation consultants. This certification program was accredited by NCCA. upon its initial application and has been continually accredited since that time. Certification is, as an IBCLC is voluntary. Currently, licensure is not required in the lactation consultant profession, although it is desired in the United States. And IBCLCs may also have the designation of registered lactation consultants in conjunction with IBCLC. And you can find this on their website. How many of you knew that registered lactation consultants is actually trademarked by FLCA? So we have one hand. Okay. In 1999, Karen Zaritsky, who was a Lactation League leader, a long-time Lactation League leader, and an IBCLC, she got legislation to say that in the state of Louisiana that lactation consultants must be in a registry and they must be an IBCLC. So you cannot be a registered lactation consultant, which is trademarked by the United States Patent and Trademark Office, without being an IBCLC. And on FLCA's website, they maintain that registry for anyone to go on there and check to see if you're actually a registered lactation consultant. The Allied Health World, on their alliedhealthworld.com, their website, they say that International Board Certified Lactation Consultants is the gold standard certification in the field and is the highest level of certification available anywhere in the world in lactation. The U.S. Department of Health and Human Services recognizes IBCLCs as healthcare providers certified in lactation care, specific clinical expertise and training of how to manage complex breastfeeding problems. The CDC recognizes IBCLCs and Lactation League leaders in their breastfeeding report card. They actually have now a column where they want to see from state to state and across the nation how many IBCLCs we have per 1,000 births and how many Lactation League leaders we have per 1,000 births. And you know that the ratio should be 1 to 1,000 would be the ideal, and you'd have to look at the report card to see that it falls short of that in most states. In Florida, we actually are doing pretty good in the IBCLC department. We need to do better in the Lactation League department. And they also, in that report card, state that IBCLCs are healthcare professionals specializing in the management, clinical management of breastfeeding, and that Lactation League leaders are trained and accredited volunteers who offer comprehensive breastfeeding support. Get a drink of water. Do the Rubio thing. Okay. Today, in ELCA, we're a 28-year-old profession. We're a standalone or an add-on to existing profession. There are over 13,000 IBCLCs in the United States. There are 512 in Florida. IBCLCs work in a variety of clinical and government and research areas. ELCA's mission statement changed a few years ago, and their mission statement is to advance the International Board Certified Lactation Consultant profession worldwide through leadership, advocacy, professional development, and research. ELCA's vision is the IBCLC is the global recognized professional authority in lactation. So we have now trumped Lactation League. We are now the authority. The professional standards for IBCLCs, we have clinical competencies, we have a code of conduct, we have documentation guidelines, we have FLC has a disciplinary process, and a scope of practice. Today, breastfeeding is recognized as a primary healthcare prevention, and our focus has now shifted to prevention in this country, which it probably should have a long time ago, but at least it's finally got there, and I think this is really important. But there are several agencies that recognize that breastfeeding should be a frontline prevention for a healthier society. It saves us taxpayer dollars and healthcare dollars. Infants' cost of not breastfeeding is an estimate of over $13 billion per year, and mother's cost for not breastfeeding for health problems she may have associated with not breastfeeding are $17.4 billion. So that's a lot of cost. I also wanted to point out that there's more cost to not breastfeeding. The WIC program buys more than 50% of all the formula sold in the United States. And that means that that's the taxpayer dollars. Working together, agencies, healthcare, government agencies, international organizations have come up with breastfeeding policies. And so this has all taken place in just the last few years. The White House Task Force on Childhood Obesity report calls for breastfeeding as preventative health care. The Healthy People 2020, the CDC report card, breastfeeding report card, the MPINK survey, the USDA WIC food packages. All of this is in support of breastfeeding. The IRS now says that you can take your tax deduction for breast pumps and other breastfeeding supplies. HRS, Office of Women's Health, has the business case for breastfeeding. We have the Affordable Care Act, and we have the Surgeon General's call to action. And this is really significant to have this kind of infrastructure under supporting breastfeeding. We've never, this is something we've never had before in our history right now. And the Surgeon General's call to action, Action 11, ensure access to services provided by IBCLCs, include support of lactation as an essential medical service for pregnant, breastfeeding mothers and children, standard coverage for IBCLCs as covered providers, provide reimbursement for IBCLCs independent of their having other professional certification or licensure, work to increase the number of racial and ethnic minorities, IBCLCs, to better mirror the population of the United States. So this is her call to action that's directed at IBCLCs. So she had there's several different action calls, but this is the one that's directed towards IBCLCs. Of course, her call to action is not law. This is in an ideal world what the world would be supporting and doing. Why IBCLCs? Because access to IBCLC services do improve the incidence and duration of breastfeeding. When an IBCLC is on staff in a WIC office, more mothers initiate breastfeeding. In a primary health care office, it promotes longer duration of breastfeeding. In a NICU, it's up 14% breastfeeding. In a hospital, it's up more than 100%. And Medicaid mothers, when there's IBCLCs on staff, it's up more than 200%. So this is significant. The call to action and all the infrastructure should ensure new jobs for IBCLCs and more jobs for IBCLCs. I want to talk about the Affordable Care Act because I call it the good, the bad, and the ugly. The good, thumbs up. There are two good parts of the law that pertain to breastfeeding. The mandate to unpaid breaks for expressing milk in a location other than a bathroom, and the comprehensive lactation support and counseling by a trained provider during pregnancy and or postpartum period, and the cost of renting breastfeeding equipment in conjunction with each birth. This is what is actually the way it's written in the law. So, I wanted to let you know what's actually in the law, and now we'll look at what has happened with the way it's in the law, and this is the bad. When they looked at the law on workplace for the mother to have a place other than a bathroom and unpaid break time, it was sent over to the Labor and Wage Department because they're the ones that enforce and oversee laws to do with workplace. And they looked at it and they said, unpaid. That means that salaried women can't be unpaid, have unpaid break time, so they're exempt from the law. So that portion of the law is only helpful for those women who are hourly paid. Then we have the access to care for IBCLCs, which falls, not IBCLCs, but for lactation consulting, and that falls under preventative women's health. And the problem that we've run into is that there are no guidelines or protocol for this area of the law, so insurers are interpreting it, insurers being the insurance companies, are interpreting it at, well, who's the trained provider that we're going to reimburse? We don't know. What kind of pump do we give them? Well, if you want to make a good profit margin, you give them the cheapest pump that you can find. And they're going through, you have to go through their durable equipment company in order to get a pump. But this is the way insurance works. If you need a nebulizer, you don't go down to Walmart and buy one. You go through a durable medical company. It's whoever the insurance company contracts with. So what we run into, which is the result of it, is that pump rental stations across the nation are closing and going out of business because the mother has to go to a durable, if she wants her pump through her insurance, she has to go through a durable medical company that's contracted with her insurance company. Some of the hospital pump stations have closed within hospitals, and this is a problem because the revenue from those pump rental stations were what paid the salary for the IBCLCs and those outpatient breastfeeding centers, and as a result, we have IBCLCs being laid off. We have a delay in mothers getting pumps. They have a baby in the NICU, and it could take her weeks, days or weeks to acquire a pump through her insurance. So we actually have less access for mothers in need of breastfeeding help, since most insurers will only reimburse physicians, nurse practitioners, and physician assistants for lactation counseling because insurers only reimburse licensed providers. So it's not so pretty, and I call this the ugly. So it's one big mess, lots of confusion and frustration for the consumers, frustration for IBCLCs and other healthcare providers. I don't know how many times we've been asked in the pediatric practice to write a prescription for a breast pump, and well, Dr. Rich writes them out real quick and signs them, but she thinks she's just going to, what's she going to do with this? She has to call her member services. So we have a whole handout to tell her what she needs to do now, so that it tells her she needs to call her member services. She needs to find out what durable equipment company then she contacts, and then that company will tell her what pumps they have available for her, and it's just a whole process. So it's become lessening. It's lessened the access of care for mothers and babies when they need it. They need it now. I'm going to take a drink again. I get real dry in my mouth. Okay. In July last year, and the press release came out on the 18th, and they posted on the USBC website, USBC and the National Breastfeeding Center worked jointly together to come up with a model policy for payers' coverage of breastfeeding support and counseling services and breast pumps and other breastfeeding services or supplies. And so this is a model. It's not mandated. It's not law. It's just a model. And Liz made that real clear on Facebook on the 19th when there was a lot of debate going on about, well, how is this really going to help us? Or now that we have this model, we can shove it down the insurance company's throats, and it doesn't work that way. Liz says that advocacy for lactation care providers like IBCLCs is a long, slow, prodding process in which, as non-licensed providers, we carry very little weight. The model policy is not a panacea. It never was intended to be. But the model policy is a tipping point document in lactation advocacy. On page 5 of the model policy, and this is kind of lengthy, but I think it's all important. The policy offers guidelines for coverage of health care providers who are professionally licensed or consistent with insurance company credentialing requirements, who have individual certification awarded by an independently accredited program that measures assessment of predetermined standards of knowledge, skills, and competencies in health-related profession, subsequently equal to those articulated by the National Commission of Certifying Agencies and the Institute of Credentialing Excellence. The ability to counsel the breastfeeding mother and infant lies within the professional scope of practice of the approved lactation care providers. International board-certified lactation consultants are an example of non-licensed approved lactation care providers with certification meeting recognized credentialing standards. There's a big difference between certification and certificate. Certificate is something you get when you take a class or a course and they give you a certificate of completion. It's a whole different process than certification and becoming an IBCLC. I'm not going to go into this except to say that in this model policy they also included donor milk, which I thought was really, really nice to include that it should be being paid for by insurance companies. I don't know how many realize the care gap there is in the ACA when it comes to lactation. The law took effect as far as lactation for being under the Women's Preventative Health Care, having services reimbursed by your insurer, only took place with those plans that were non-grandfathered. And for those people who don't know what that means, it means that if your policy has a certain time of the year that it renews, and until it renews, it's in the grandfathered place. So when it renews, then the law would take effect. Most of them renew annually, but some do not. So it might be several years before that particular person's policy is available on that policy. Also, we need to point out that in 2012, Florida Medicaid births were 50.9% of all the births in the state of Florida. And about 20% of uninsured people who can't qualify for Medicaid, they just fall into the gap. Medicaid will not reimburse for services by non-licensed healthcare providers. Now, some wonderful people with USLCA like Marsha Walker and Judy Gutowski have had many, many meetings with the powers to be with Medicaid in Washington, and they've had face-to-face with them. They've had conference calls with them. They have tried all kinds of different angles to try to get reimbursement for IBCLCs under Medicaid. But the bottom line is we're not licensed, and they don't pay unlicensed providers. So they don't want to hear it. So there's a huge number of mothers and babies who have no means of affordable access for breastfeeding help. Only about 20% are covered under the ACA. Mothers and babies need clinical evaluation and care plans. You and I know that it takes at least an hour or more to do a really good job of an assessment of mother-baby and watch the breastfeed and to really do a good job. Most physicians and other healthcare providers don't have this kind of time to spend with their in a consult. So where is the help for mothers and babies when they need it? The U.S. Surgeon General presented the solution in her call to action when she said that standard coverage for IBCLCs as covered providers. And she also said that alternatively, develop state licensure for IBCLCs. In the past, when we've talked about licensure, and this particular group hasn't talked about it in a while, but it was a hot topic a few years ago, the first argument always was licensure will not guarantee reimbursement. That argument is off the table now. The infrastructure and the layers and is there. That's all that's holding IBCLCs back from reimbursement now, is the fact that we're not licensed. Medicaid and private insurance would be reimbursed if IBCLCs were licensed. The second argument against licensure has always been it's too expensive. Now it's too expensive not to be licensed. It limits the growth of our profession. It limits our job protection. It limits access of mothers and babies to the lactation care they need. And how would licensure affect those without a license, that are lactation consultant doing lactation consulting without a license? Other professionals like doctors and nurses can still provide clinical lactation support because it's within their scope of practice. But they would not be allowed to call themselves lactation consultants without a lactation consultant licensure. IBCLC licensure would not affect the work of WIC peer counselors, since they're either volunteers or they're paid by WIC. IBCLC licensure would not affect the work of individual volunteers or volunteer breastfeeding organizations like La Leche League. IBCLC licensure would not affect the work of breastfeeding educators because they can still educate on breastfeeding. Others interested in providing clinical lactation care should become IBCLCs. The prerequisites, the standards have been raised, and the prerequisites now are 8 college-level science courses, 90 hours of lactation-specific coursework, 300 to 1,000 hours of supervised clinical care. You must pass the FLCA exam, and every 5 years you have to renew. And we also have to adhere to a code of ethics and scope of practice. The Surgeon General and the CDC recognizes us, IBCLCs, as the lactation experts. This is to help everyone to see the difference between a certification and a certificate program. And the primary focus of a certification is independent assessment and knowledge required for performance and role plus other requirements. So we have a lot of requirements before we can even take the IBCLC exam. It's done by an independent body. FLCA is separate from IBCLC. And FLCA is also has to go through those layers of credentialing with all those other agencies. A certificate program is where you go and take a training or a course and they award you a certificate of completion. There's no comparison between the two. The program content with a certification program has to be based on practice analysis, where in a certificate program it's not required. In a certification program, you have to have governance that's represented by key stakeholders. So there are independent people involved that have no relationship or benefit to the outcome financially or any other way. In a certificate program, there's no governing body required. The education and training, the assessment with the certification, assessment not linked to a specific class, program, or educator provider. So you can get your education for lots of different areas or from the same area, but it's not linked to the directly to FLCA who's giving the exam. And in other certificate programs, the education and the certificate is linked to, it's all within, it's in-house. Assessment, the certification is required to certify and to be recertified. It's a proctored environment. It's scored and developed differently than a certificate program. Credentialing maintenance, there's a time limit. Ongoing professional development, with certification, there's a disciplinary process, and that's very important. In a certificate program, there's generally no requirements. You get your certificate, and you got your certificate from completing your course. With the certification program, you're designated. So you have a designation of, could be lots of different things. In our case, it's IBCLC. But with a certificate program, you only have a certificate. So you have a piece of paper, basically, and that's it. So what about the CLCs, the CLEs, the WIC peer counselors, the Lactation League leaders, and IBCLCs? You know, my feeling is if we're going to have a breastfeeding culture and return to a more breastfeeding society, all of these people are important to breastfeeding. They're all valuable and important to breastfeeding. One role is not more valuable in its efforts than, say, another role. Just as any culture, society, and family all play a part in the success of breastfeeding, so do the different roles in breastfeeding helpers. Distinguishing between the roles doesn't render one role more valuable than another, but rather allows the mother to access the right kind of care for the right time and need. One of the most important roles of all breastfeeding helpers is to make sure the mother receives the right level of care for the situation she's facing. You know, when moms, they continue to call me after I've helped them with their overcoming their sore nipples or whatever it might be, but you know, then she calls me months later and she's having sleep through the night issues. Well, I'm going to talk to her and I'm going to give her some advice and things, but I'm also going to really try to get her to go to some peer groups. You know, my favorite is the Lactation League, but I also refer to the hospital groups. I tell them about all the groups. So, and I say, you know, go to them, and if you really you feel comfortable there, then stay there. If you're not comfortable there, there's other ones to try out. But you need to be around other breastfeeding mothers so you find that your baby is doing the same thing that everybody else's baby's doing. And I can't provide that to her. You know, I'm a grandma. My grandson's 22. It's been a long time since I've had babies. And she needs to have that from another woman with a baby sitting in her lap, not me with my baby doll in my lap, who doesn't wake in the night. But there is room for all of these counselors or all these helpers, all the helpers in breastfeeding. There's a place for all of them, and a very needed place for all of them. We can and must work together to create a culture of support that mothers and babies deserve and the future of healthier mothers and babies depends on. I want to look at another model in healthcare. I want to look at birthing helpers so that we can just kind of get an idea that there's lots of different levels of different disciplines. Birthing helpers, we have our obstetricians, our midwives, our nurses, our doulas, and our childbirth educators. And they're all valuable to mothers giving birth. But they all have unique and different roles. Yet they are all equally valuable to birthing. The midwife, nurse, and doula can't do an emergency surgery. But all these disciplines are all unique and valuable to mothers giving birth. They're just not equal to each other. Let's look at nutritionist. The term nutritionist can refer to a registered or licensed dietitian. Nutrition counselors, certified nutritionists, and even people who offer nutritional advice without any formal training at all can be called a nutritionist. All of the above might be paid by an employer or a private client. But only registered dietitians credentialed with the Academy of Nutrition and Dietetics can become licensed and billable to insurers. IBCLCs are the heavyweights. We are the gold standard. We're recognized by the Surgeon General, the Department of Health and Human Services, and the CDC as the experts. Our other helpers, are not equal to IBCLCs. But we're all important to helping with breastfeeding, and we can help more mothers and babies working together. How can we create more access of lactation care to mothers and babies? The Surgeon General has the answer. She said develop state licensure. In Action 11, alternatively, develop state licensure for IBCLCs. Why licensure? Licensure establishes IBCLCs as part of the healthcare system. It creates professional credibility. It aligns us with other regulated healthcare professionals. Ladies, I can't go get my nails done and pay someone unless she's licensed with the state. But I'm going to touch her breast and hold her baby and without licensure. Licensure provides a path for eligibility for reimbursement through Medicaid and private insurance. It creates greater accessibility to IBCLCs by most all mothers and babies. With reimbursement, physicians will be more readily willing to employ IBCLCs in their offices, making it easier for moms and babies to access IBCLC care. I've been with the same pediatrician for 18 years. In his office, we have a lot of nursing toddlers. Everyone in that office has seen a lot of breast. We had one employee, a new employee one time, and she came out and she said, "Oh, I can't believe I was doing something with the baby, and she just, the girls came and I had her breast right in my face." I said, "Well, if that bothers you, you can find another job, because if that bothers you, that's going to take place in this office." And but the thing in our office is, if a baby starts to slide a little bit on the weight, it's addressed right away by guess who? You need to talk to Pat. You need to see the lactation consultant. Since we broke off from the large group we were with, and now it's just, we started our own thing. He started it, I followed. We've been there, it'll be 7 years in October. We have not had one readmit. We have not drawn one bilirubin. We have jaundice babies. They're yellow. Sunlight and lots of feeding. We fix the feeding. We stay on top of it. They got my cell phone number. We're working together as a team, so it can work. And, it would be great if even 50% of the pediatrician's offices had IBCLCs inside them. Because that's where you see the not back to birth weight at 2 weeks. That's where you see the baby between 2 and 4 months because mommy's doing EZO, or she's taking the mini pill and it dropped her milk supply, or she went back to work and whatever, and now the baby's weight's plateaued or it's not gaining like it was. And just like having more IBCLCs could be employed. So this would be a really good thing. Reimbursement for services impacts the potential growth of our profession. It attracts younger generation with a livable wage, because the average age of IBCLCs in this country is 50.3 years. Okay. Why licensure? Licensure would provide a career path for CLCs, WIC peer counselors, and others. We need more jobs. Licensure would create and protect IBCLC jobs. Licensure would improve access to competent clinical care and improve breastfeeding rates. Licensure would improve the health of our mothers and babies. Licensure would save healthcare dollars. So it's a win-win for everybody. We IBCLCs never before have had the institutional agency government, has institutions, agencies, and government done so much to protect, promote, and support breastfeeding with strong policy. Just wait to January when the Joint Commission starts looking at the documentation for how many babies are getting formula when they're supposed to be breastfed. So this is really strong policy. The number of women initiating breastfeeding today is the highest in decades, but the duration rate is low. What does that say? Women are not getting the help they need. Never before have IBCLCs had the opportunity to capitalize and raise our profession to its fullest potential. When USLCA was formed in 2006, Linda Dickinson was the first president, and I heard her speak, and she said, "We are at a tipping point." It's like that haunts me ever since I heard it in 2006. I've heard over and over in my head, we're at a tipping point. Okay? What do you do when you're at a tipping point? What is a tipping point? But that has really stuck with me, that tipping point. Liz Brooks. You have to forgive me. I was close friends with Liz Baldwin, and if none of you know who she is, you ought to Google her. She's no longer with us. But Liz Brooks said in her Facebook post that the model policy was a tipping point document. So what is a tipping point? So I Googled tipping point. And I found that Malcolm Gladwell had written a marketing book back in 2002 that was a bestseller. It was called The Tipping Point, How Little Things Can Make a Big Difference. So I thought, I don't have time to read this book before this presentation, but I want to know what it says. So there's lots of commentaries and reviews. So I dove into them. A tipping point is I know that this picture looks like it was made just for us, but it was actually on a college website. They had a commentary on this book. And I don't know what that artist was thinking about at the time that he drew this picture. I don't know what he was thinking about because it was just there. And I thought, wow, this looks familiar to me. So a tipping point is the critical point in an evolving situation that leads to a new and irreversible development. It's defined as the moment of critical mass, the threshold, and the boiling point. It is the point where everyday things reach epidemic proportion. It's the ability to recognize and credit big accomplishments to being in the right place at the right time and capitalizing on it. The theory of the tipping point is that it requires that we reframe the way we think about the world, looking beyond our intuition and concentrate our resources on a few key areas. After all, the world may seem like an immovable, unchangeable place. It is not. With the slightest push in just the right place, it can be tipped. The profession of IBCLC faces challenges, and leadership means facing these challenges head-on. One of the challenges we face is sustainability, and some may not feel that way, but I'm going to share with you some of the reasons I think that this is an area of concern. And I keep hearing those who are of my age, when they speak, say we need more IBCLCs and we need younger IBCLCs because we've got a lot of IBCLCs on the verge of retirement. One of the things that concerns me is that we only have about 4,000 people who are members of USLCA and ELCA out of our 1,300 IBCLCs across the nation. And to have such a small portion of members of all the IBCLCs in the nation reduces the funds for member services, and it reduces fundings to support things like licensure and to promote our profession. Some IBCLCs are not recertifying. more IBCLCs are needed to replace the older IBCLCs who are retiring. There needs to be more IBCLCs at ethnic and cultural diversity. We now have new FLCA requirements to raise the education and the clinical standards for sitting for the exam, which requires clinical instructors. There are not enough clinical instructors to supervise aspiring IBCLCs. This is from ELCA's website. And, you know, they now are letting you list for free on their website. They used to charge if you were a clinical instructor, but they need clinical instructors so badly that it's not a fundraiser any longer. It's just a necessity. So they're now letting us list for free on there. And there are only 14 IBCLCs listed on the entire websites for the entire United States, and only one in Florida. The next generation needs mentoring, and they're going to need someone to supervise them for their clinicals. IBCLCs are the gold standard. IBCLCs need to reach for the gold to ensure our profession grows and is always recognized as the gold standard and has sustainability. The formation of USLCA has been a big leap for us. That's been a wonderful thing that's happened. So we're real pleased that we now have our very own association in the United States to focus on our needs in the United States and not globally. Their goals are different levels of goals. Their mission is to build and sustain a national association that advocates for lactation professionals. Their vision is that IBCLCs are valued, recognized members of the healthcare team. Their public policy committee focuses on support of local and state legislation efforts and seeks to promote and protect the role of IBCLC. And their licensure and reimbursement committee hopes to fully integrate IBCLCs into the U.S. healthcare system in order to provide consumer protection and ensure that skilled clinical lactation services are available and provided equitably. And the only way we can have it provided that way is through licensure. So where does FLCA come into this picture? Well, FLCA has a mission statement. We revised our mission statement a few years ago to align it better with USLCA. And our mission statement is, FLCA is dedicated to building and sustaining a statewide association that advocates for lactation professionals and the advancement of the profession of IBCLC. Wonderful. Really pleased with that statement. What is FLCA's vision? Well, we don't have a vision statement. So what is our vision? We have to determine what is our vision. We can't go into the future without a vision. Tomorrow will be our future. So I got a few suggestions here, and I'm not necessarily terribly pleased with them or anything, so don't, I just threw something on the slide. By this point, I was getting a little tired, so, and my creativity was running out, but I said, the IBCLC is the recognized professional authority in lactation care in the state of Florida. Or, Florida IBCLCs strive to ensure access of lactation services by IBCLCs to the mothers and babies of Florida. I don't know. That's for FLCA to determine what our vision is, but I think we need a vision. I think FLCA also needs a strategic plan. A strategic plan is an organization's process to define its strategy or direction and make decisions on allocating its resources to pursue this strategy. There are two committees I would like to see formed, and really not just say, oh, we got a committee over here, but nothing's being done. I would like to see some real action. And one would be a mentorship committee where we work to have more clinical instructors in the state of Florida, where we suggest a list of online and facility, whether it's online or facilities themselves. I was real pleased that the USF put out I don't know how many of you saw or took place in the survey. They would like to develop a lactation course at University of South Florida. And that would be awesome. It would be the first in the state of Florida to have an actual lactation course that would bring them to the point of taking their FLC exam. But the survey was a needs assessment survey, so if you didn't participate in it, if you would like to participate in it, somebody let me know and I'll send them the link. But if people don't participate in it and they don't find there's a need for it, they can't develop one. But we need to help others know where to get their education. We need to develop study groups for the exam and have some scholarships, which we are doing scholarships, but we might want to look at expanding that. A licensure and legislative committee, and what their work would entail would be networking and identifying stakeholders and form alliances. I was so happy to hear Mary share the story about what took place in Jacksonville, and those are the kind of things that you don't know who your stakeholders are out there and who you might be able to collaborate with that might have some clout and help elevate something. And that's a beautiful thing that needs to happen more. And we need to be looking for those opportunities and building those relationships so that those things can happen. Create an action plan and begin pursuing licensure for IBCLCs in Florida. It's challenge time. Do IBCLCs risk their profession floundering or dying off? When we do nothing, we feel overwhelmed and powerless. When you get involved, you have a sense of hope and accomplishment that comes from knowing you are working to make things better. The time is now to promote, protect, and support the designation of IBCLC and create greater access for mothers and babies to IBCLCs. I've heard Kathy Crothers speak several times, and as these layers with government agencies and things have built, she keeps saying over and over, the time is now. The time is now implies to me that we can't wait much longer. The time is now. I want to thank all of these ladies who have had some input to this presentation. All of these ladies have spoke on similar talks on this line. They're on the Licensure and Reimbursement Committee, and we have conference calls and lots of email exchanges and work together. Marsha Walker actually wanted me to open this up to all of the whole United States when she saw the presentation. And I said, but this is FLCA's, and if we have everybody on there, FLCA people won't be able to log on. We can only have 100 seats. So, but they recognize that this is very important. Now I'd like to ask you to write down this survey, because we want to know how you feel. Ooh, went faster than I should have. We want to know how you feel. This will be your evaluation today, but we also want to know your feelings about what you're thinking. So the survey asks us some very important questions that will help give the FLCA board some guidance towards your feelings. Pam?
Will we have a question and answer session?
I'm not sure. Let me see here what I've got going on the internet as far as questions and that.
We certainly have time.
Yes, we do have time. Yeah. I want to just see if I can check with one of the attendees. If you'll just hold everything just for 1 second and let me see. Judy, are you there? Okay, you're going to have to speak up really loud, but would you like to say anything to FLCA? This is Judy Gutowski, who is the chair. Judy, thank you. I know you're on vacation and you're with your family on vacation, so I appreciate you just sharing that with us. You know that I'm your kindred spirit in this effort, and we'll keep plodding along. But thank you. I don't know if any. I know that she was really low. I don't know if you could hear her. Yeah. Mostly she was just thanking me for the presentation today and encouraging Flicka to really think long and hard about the licensure because it is really important to our profession. It has to be done state by state. These kind of things can't be done nationally. We don't have a state that's actually accomplished licensure yet. And Georgia was really close and got thrown a little curveball, but I think because they didn't know the curveball was coming at all, I think that we learned a lot from that. I think we learned a lot from Texas and some of their efforts, and so that as states go forward with working on this, I think we can be prepared for some of the problems that they've run into. Oh yeah. Yeah, I'm trying to, I can't see their questions unless I have that open. Pam?
You expressed some concern about getting new IBCLCs in the field. Where do you see the recruitment coming from?
Well, there's a large number of CLCs out there, and they're passionate about breastfeeding, and so there's a large group of people who could be IBCLCs.
I have another question. The licensure, would that complicate it at all to become an IBCLC?
I think it would enhance it.
Well, I understand it enhance the profession, but are there stipulations in being licensed that might make it more difficult for a CLC to become an IBCLC?
But if you become an IBCLC, will you automatically have licensure go with it, or do you have to do something extra?
There's two different things.
Yeah.
Licensure is written by the state, by the medical examiners, by the code of the state. And IBCLC is a different act.
I understand, but
I can't be a nurse in two states unless I apply to the new state.
So we might not be an IBCLC in California to become a licensed.
No, you'd still be an IBCLC, but your license would be in whatever state you were in. And of course, with many states, they have, yes, they reciprocate or have proximity, yeah, reciprocity, so that they can participate in more than one state. But you know, with licensure, you're going to have to pay a licensure fee and renew your license. So that's a downside. But you know, to have a viable profession that can get paid is kind of nice too. I mean, to put all the work into becoming an IBCLC and then find that you can't make a living, you can't get paid isn't a great thing either. And then to have mothers who call you on the phone and say they want to come see you, but oh, my insurance is not going to pay this. You're an out-of-network provider. Oh, I thought you would just see me and bill my insurance and hang up. How many have had that happen since the new law came out? Yeah.
When you have, then if you become your IBCLC, let's say licensure is now, so let's just fast forward to licensure. If I become an IBCLC, you're saying then I don't automatically have that licensure component unless I apply to the state for it. So I think
Yes.
your question, Pam, was, is it going to make it harder for an IBCLC? What do they have to do to get that license so I can do it?
They have to become IBCLC first.
Right, but if you are,
So it doesn't make it any harder to become an IBCLC. Bonnie?
With a nurse, you have to take, you know, your domestic violence or medical errors or something every 2 years. So it's a very small component of a continuing education that they might tack on to your licensure. But the other thing, Pat, isn't licensure ideally was about to protect the public?
Yes.
So that when the public is looking to have a service, it's the idea is to protect them.
Yes. Just like if I want someone to put a roof on my house. No, do I want to hire someone who, off Craigslist, who doesn't have a contractor's license and he can't pull a permit because he doesn't have a contractor's license, and no one's going to come and inspect his work but my neighbor might report me for having this guy put this roof on my house with because they didn't see the permit out front, because I'm required to have a permit to put a roof on the house. So they're going to, I'm going to get caught in this dilemma of having to tear off the new roof and throw it in the garbage can and go find a contractor who is licensed to put my roof on. Well, that's the way it works. That's real.
Who are we protecting?
Yes.
We're protecting the consumer and the
It's both.
we're protecting the process.
Yes, we're protecting the process of which we have in this country. This is the healthcare process. This is the process with things outside of healthcare.
And I have two concerns. I've been in this profession a long time, and I think to have more IBCLC, the hospitals are going to have to allow the IBCs that are there to train outside people in their institution hands-on. When I asked Healthcare, I said, they can come and observe. They said, oh no, it has to be hands-on. And hospitals are not allowing that because of liability. Second thing, and I even asked Phil for this, when we need so many IBCLCs, why are they making requirements so much harder?
Well, the requirements are made harder so that we can raise our standards and align them with other healthcare professions. And that's really needed to have the recognition we need. I don't know that it's all the reimbursement. It is to get up there and have the same alignment as other healthcare professions. With any healthcare profession, and what I did is I went back to study, I went back and read about nurse practitioners and how they became, because they're a newer profession. And with all healthcare professions that we have in this country, we didn't all start out, you used to just be able to hang out a shingle and call yourself a doctor at one time in history. Everything has been an evolving evolution, but it has always been building and becoming to what we have today as our standard that we have for our healthcare system. And that's what we've brought our profession up to the level with everyone else's.
I think the frustrating part, and I know that, I have to certify next year, that's the frustrating part is I'm a registered nurse. I board one time. I maintain my CEU, stay out of trouble, and I maintain my RN status. For IBCLC, yes, I need the continued education, and I agree with that. But I have to reboard every 10 years.
And so do doctors.
It's not a $60 board, it's a $500 board.
Yeah.
Or say $500.
Yeah, yes.
The education, the money, it is necessary. The only way we are going to be taken seriously if we have experience and education to back up. Where I work, there are people running all over pretending to be IBCLC. The 1 or 2 days that are there, people put themselves down and call themselves, oh, I'm the lactation nurse. I would never say that. We can't be accepted by our pediatricians or by our neonatologists unless we say, yo, I'm the IBCLC. I'm a registered lactation. They won't even listen to us. So yes, it's a lot of money. Yes, I have to pay. And yes, I pay thousands of dollars of going to all the different conferences so that I know I have my CEUs. But it's the only way we can do it. And right now, there's such extreme budget cuts.
Yes.
At the hospital rise.
Mm-hmm.
I can't even get nurses. We don't have time to be health. I mean, you guys don't realize that
Yes.
diminished.
Mm-hmm.
$9 at night an hour, our hours are being cut. So the first thing to go is the resident. I hate to say it. I grind. I pay. I cook. I do. You should see. Thank you for helping my mommy's breastfeeding. And I'm hoping that time I don't really want to. I'm really down. I really don't want to, but I've had it. Oh, but you made me. Okay. I'm serious.
Oh, yes, we know.
In fact, when I first became an IBCLC, before I became an IBCLC, I had lots of experience from election. When I came to the hospital, I was shocked. Some of the IBCLCs never been breastfed, never had much hands-on, and the hospital lied. So they could take the exam and say we have 6 IBCLCs. I was shocked. I didn't think they would do this. See, that's something else we have to think of. Why we have to maintain such high standards. And we have to start making IBCLCs accountable. If you vouch for someone that they have this much experience, they really should have had it. I saw people taking the exam that I knew had no hands-on experience because I was the only one at the hospital at the time. And if they had hands-on experience, they would be following me around. So I really think, I don't know why, but I really feel strongly that we have to keep the standards up high.
Yes, to do that, we all have to work together. And we have to be accessible to help be the ones that are there to help supervise these others. And I understand that some of the problems, but we have to, as a people, just like we should as a citizens of this nation, be telling people who make the decisions how we feel about things. Because if we don't get on our emails and we don't send them messages and we don't say, I'm not going to vote for you again, we're not going to make any change. But this is where we need to be collectively. They need to hear from lots of voices, ELCA and so forth. Help us with it's actually USLCA we should be saying to them. How can you help us with this problem? We need some kind of something here to get past the risk management. Come up with something creative that we can work about getting these people in for clinicals. I mean, my daughter's in nursing school right now, and she's doing clinicals in the hospital. She's a paramedic, and she has better skills than most people she works with. But, the nurses can't do IVs or some of them and innovate anyone, and she could do that. But, we need to be, as you see, USLCA, we need to bring, and we need to have more people than just one saying this. We need to be saying it. We need to tell them what we need. Yes, we would like to train more IBCLCs, but, we have these roadblocks. Help us remove the roadblocks. That's what we're doing in breastfeeding, isn't it? We're trying to remove the barriers to breastfeeding. Well, we have barriers in our profession, and we have to speak up, and we have to come up with some creative ways. We're women. We're creative. We can do this. Pam?
I was interested in becoming a clinical supervisor and then contact yoga, but we used to have reset more times. I won't be on until next year.
Mm-hmm.
Yeah. But I think the health department is a wonderful venue for supervising clinical hours.
Yeah.
During our volunteer clinic,
Mm-hmm.
so that we and also I'd like to recruit even high-level peer counselors. We really get serious amount of hours working as a volunteer or as a lowly paid peer counselor. You can rack up those hours that you need and then be part of a supervised clinic at Orange County or other county offices to start. I would like to get mentored on how to do that because I can't say that I have that supervised.
Well, ELCA has a program to put you through a educational program, and you go through this program, and then you're tested, and then they say you're a clinical instructor.
So I'm going to get information on the IBCLC website?
Yes.
And I just put it in supervisor.
It's there. It'll take you over to, if you go into USLCA, it's going to take you over to the ELCA website. You log in as a member. You have to be a member. Some people aren't members. To log in as a member, and then you would take the course, and you get it for a reduced fee, because it is a fee for the course. And with the course comes a test at the end of it, and then you can be a clinical instructor and listed on their website.
Our clinical scholarships to sit for the clinical exam are for new builders or only
New IBCLC.
new IBCLCs?
Non-resident.
not discussed.
Okay, Carrie?
The thing we need to look also as a state and national organization is that just because we've got licensure and this is what it states, you know, who's an IBCLC, what are the requirements for an IBCLC, what are we licensed to do, that puts us open then for the state legislators at any time to try to come in and tack things onto or take away. So besides just having licensure, we would also need to look at who's going to help us monitor then at any given time on a state level what's going on, where something in a future bill or something like that then may impact our state licensure. So then we need to look at, as a state organization, additional costs and possibly covering a lobbyist or somebody else that's going to protect our interests once we have that licensure too. So it's just not licensure. We need to be thinking about it a little bit larger and beyond that when we start looking at a state level. What are these costs and what are these things going on?
And that's true. There's two ways to do things. You can either be under somebody else's board, and that governing board, I think nutritionists would fit real well with lactation consultants because we're about feeding babies. Or you can set up your own board. And in your own board, you have your own, I won't say that it's really like your own people, but it sort of is. It's going to pull from yours and other disciplines, several different disciplines it pulls from. So you'll have someone represented, say with FLCA on your board, but there may be doctors and other people on that board too that would be the governing board. But you always can have in any kind of legislative process where you're part of the system, you can always have laws that conflict with your interest at different times, but that can happen with doctors and roofers or anybody. Yes?
Well, I like what you said, that was voluntary. You become IBCLC and not choose to get your license.
Yes.
Right?
Mm-hmm.
So that for me opens up support. You want to get licensed, you got my support. I can still choose not to for whatever reason if I don't want to. But I'll support everybody else who wants to be licensed.
You wouldn't be able to get reimbursed.
I don't need to be reimbursed. I'll support every IBCLC who does.
Well, because you're employed by an agency that pays you your paycheck. And yeah, yes.
That opens up a lot of doors to people who are on the fence.
Mm-hmm.
If they're on the fence,
Mm-hmm.
they'll support you. I'll be licensed, I'll support you, I'll vote for it. Your employer might require it.
Well, that might evolve. And that could evolve.
State licensure, most then employers require you to be licensed then under that profession to put those initials on to be paid at a certain rate. Yeah.
Bonnie?
Licensed nutritionist, I have a nutrition educator.
Mm-hmm. Mm-hmm.
You could be under that part and not go to that extra mile.
Yeah.
I still like the choice of it.
Has Marcia Walker recommended as far as when they're going for licensure in the state, whether or not to create their own board? Because it's not like nurses where there's thousands of thousands.
Yeah.
And so the cost will be less, as opposed to when you only have, a few hundred, it's probably more cost effective to be under another.
Well,
She's talked about.
Leah Aldridge is an attorney and a IBCLC in the state of Georgia who's been working on their legislation. And it was her presentation at USLCA that just really kind of pumped me up, And I would like to see her speak at our next FLCA conference so that she could share more with you, because she's done cost analysis on this, and she says it's really not that costly to set up your own board. So, I would really like her to speak for us. I mean, Georgia's.
$100 a year, but that's not much if you're getting reimbursement or protection or whatever.
Mm-hmm. Yeah. I want to see if I can talk to Esther down in South Florida. Okay, she's had her hand up for some time. Esther, can you? There you are. Now you're going to have to speak very loud for us to hear you. Esther? Wait, let's take one question. Hold your other question. Let's take one question at a time, and I'm going to try to answer that question because we're having trouble hearing you. You need to speak up really loud. But I think you're asking if we can collaborate with USLCA on this. Is that what you're asking? Oh, okay. If this is for FLCA to decide. This is their profession, and FLCA is the association for the IBCLCs in the state of Florida. So they need to decide what to do. But I can tell you 100% that the Florida Breastfeeding Coalition will help them as much as we can with that effort. So that part will be collaborated on. Yeah, I think you're correct in that, but I think this is another one of the barriers that we have to be creative about finding a way around it. And I think that having mothers in a WIC office who are coming in to have WIC help, and you having students there as a clinical student, so it's going back to what you were saying, that would be a really good place to have clinicals, but we also have some barriers with the state rules and regulations as to privacy and who can be involved in those.
They have to be employed by as a volunteer with a background check and all of that.
Yeah.
Before they can do that.
That she was saying that they would have to be employed as a WIC peer counselor to have the background check and so forth in order to.
Yes. Volunteers.
Yes, the volunteers could go through that process. Regina, I think I follow you. I think you're, definitely whatever, if we were to put something into action where we did have WIC more involved in this process of supervised clinicals, we would have to clear it with Tallahassee, and there may or may not be some barriers there. I don't know. We have some new people up there. There's been a big turnover in Tallahassee, and we've got some new people up there that are calling me up and saying, can I be on your monthly call? I really am interested in breastfeeding. So we do have some allies. We just have, it's that right place at the right time, and we have to be actively working on it. We have to be networking with people to make these things happen. Any other questions from South Florida? Should FLCA develop one, I'm sure they'd love to have her on it. I made suggestions in my presentation, so FLCA has to decide. Okay? You're welcome. Pam? Mm-hmm. You know, I've got one at home. I didn't even think about bringing it, but that would be good for the next time, because I have one of those, so because I don't want my speaker with me. I have an extra. Yes.
I just wanted to mention, and I have to talk about it, I just want everybody to know, with this webcast that we've done today, you know, we look in the room, this is about the population we have. We had, I'm walking on, we had minus many but with 136 members, we had
Well, I want to say that some of these are on the FLCA reimbursement committee. Marsha wanted them on this webinar, so I have to. That's exactly right, and I have to decipher out when I get the report who's actually in Florida and who's not. No, they're all in one room together. So, well, they're going to send me a sign-in sheet. I'll know. We'll report it in the minutes. Yeah. Okay. So, this is being recorded as we talk. It's going to be put in the membership, and I'll put my slides in the membership. Okay.
Could the people who are listening not type in your questions, you know, like they do at some of the other
They could.
webinars?
They could.
So as you go along, they can type in questions, and at the end we can go down and answer them.
Yeah, there's none in there right now, but they can. See, I can see. They can type them in, but I just thought it would be nice, since I knew that South Florida was, they were all together there. I thought it would be nice for them to be able to hear our voices and for us to be able to hear their voices.
Just so I can states and other countries that are licensing right now.
In other countries?
For states.
In the United States? There's
And other states can other states.
Yes. No one has become licensed yet, but there are many other states where they're in the process.
But right now, no other states.
No.
Other countries may have licensure, or they just have
I have no idea how the healthcare systems work in other countries. All I know is the rest of the world is ICD-10 and has been for about 10 years, and we're still ICD-9. And in October of next year, we're supposed to go ICD-10, and I'm not holding my breath, because Americans don't like change. In the 70s, we were going to go metric. My husband went out and bought every metric tool. He was ready. And we never went metric. So I don't know. We'll see what happens, because so far the Department of Health has pushed it back and pushed it back and pushed it back. I don't know. You know, I just But anyway.
What has been the challenge in other states that are fighting for blood control?
I'm going to end the webinar now, and I thank everyone who joined us. We really appreciate it. And if you have any questions, you can email me at patibclc@aol.com. That's patibclc@aol.com. Thank you. Well, before we had this infrastructure, that has just been awesome, what has taken place in the last few years of